I found it interesting. Steve mentioned that I teach at the Chime Boot Camp, and I do that twice a year. And I've been doing that for the last 4 or 5 years. The thing that's valuable about that is that I get to see, based on the questions that are coming from 40 to 60 IT professionals, each time we teach, there are a different set of questions. And this last time I was talking to the group about vision and strategy, and I said, how many of you now have a piece of work that you're talking about, something that's taking up resources, that's called optimization? And all the hands went up. It's like, what the heck is that? Where did that come from? We were all talking about EHR implementation only 2 years ago, and change management. We had change management strategies. We were looking at how to engage our physicians and how to design this and how to put it in. And one of the things that came up during that conversation was a story about a CIO who's recently finished an implementation of a large EMR. And all of us now are pretty good at this. It's textbook. We all know how to do it, and our vendors are good at it too. So we get the right consultants, we create teams. You heard both Scott and John talk about how they've engaged physician champions and groups of clinical leaders to design their systems, to be involved in their systems, to have a lot to say about how you set it up. You go through absolute good design, building, testing, you put it in production, you put out a playground, you let everybody play with it, you do training, and you implement it, and you have at-the-elbow support. You've got all of this support. You do a textbook install, it goes beautifully, and as John said, and everybody goes, but it sucks. And they hate it. So she goes, look, we just did this install. We worked our tails off. We spent millions of dollars to do it absolutely perfectly, and they hate it. So where are we now with the fact that they do? Now, the one thing I do want to say, and Steve was very kind, but you can tell, if somebody's had that many jobs, they've been around for a really long time. And the part that he didn't say was that I had a consulting job before that. My first operational job was as the director of data processing at Torrance Memorial Hospital back in the Jurassic age of computing, when you had a data general in the basement and a bunch of dumb terminals and dip switches, and there are only like 5 heads nodding in the room, so you all remember. Which means I've been installing iterations of this for many, many years, and we've gone through first doing patient accounting, and we put in all kinds of systems for that. And we saw what was wrong with those, and people told us, well, it doesn't do this and it doesn't do that. The first patient care information system I put in, nursing stands there and they go, we know what this is. This isn't a patient care system. This is a big charge capture system. And they were right. It was built on a patient accounting platform, and it helped us track all of the tests that were ordered, and it did get results back up to the floor. That helped. But it wasn't a platform that anybody could use to practice medicine. It was really an exchange of information, and it really helped us a lot with better billing. And it helped us a lot with better coding. But we didn't get to the point where we had anything. I know the first time I looked at one of these advanced EMRs, and I finally went and saw a demo, and I thought, oh my gosh, there it is. I've been looking for one of these for years. This is fabulous. They're going to love this. They stay happy with anything you do for a nanosecond. Seriously. And then they're gone. And I was just talking with one of our teams at Sutter Health, and I said, we have to appreciate within our own ranks the level of quality of the work that we do and how hard it was and how well we did it. Because to everybody else, the better we do our jobs, the more invisible it is to them. And as we said, it's table stakes. $100 million of software and implementation cost, and it's table stakes. But it is. So we got the EMR in, and now what do? So we've been talking this morning a lot about the larger macro picture of population health. I'm going to go a little bit micro, which is we still have to optimize the way the EHR works for our caregivers. We're not done there. We can't forget that. We need to spend time there. So I'm going to talk a little background of Sutter Health, you need that. And then we'll talk about our optimization journey at Sutter Health, what we've done. I'll give you a couple of examples from 2 of our regions, just 2 different things that we did that are scalable, whether or not you're a hospital or whether you're a health system. This is an idea and an approach that you can use to work. So we're going to do a little bit more roll up the sleeves and get a little more hands-on this afternoon. So Sutter Health, and we're one of those health systems that doesn't talk a lot about ourselves. We've just been busy sticking to our knitting and competing with Kaiser in Northern California, which is tough enough. And we're actually the 11th largest health system in the country, and I just found that out this year. It's not something we've ever said about ourselves, but it's important for people to know. And we're in the process now. You can see how many counties we cover. That's kind of the big part of Northern California that we touch one way or another. And we're in the process, and we'll launch it in January, of going from 5 regions to 2 divisions that are more market-based. We're recognizing the importance of leveraging the health system and of being more consistent in the way that we operate. And this is an idea of just kind of how big we are. Our EHR journey, we're now the largest single instance of Epic in the world. I don't know how long that's going to last, but we are. Now that tells you that as we try to work through optimization, we have to do things that work for the whole health system because we're all on one EMR. And there was a reason for that. It makes it harder in some ways, but it knits us together as a health system in terms of what we really mean by providing great patient care and what best practices are and how we can leverage what we know. So that gives you an idea. We do have over 1 million users on My Health Online. So we have engaged our patients, and that's been one of the important parts of the journey, is to get the patients engaged in their own care. So this is just a few of the articles that you've seen popping up out there. Every time you log on, you're seeing these things. Dissatisfaction, physicians don't like it, they don't like the design. 92% of nurses are dissatisfied with their hospital's EHR. And then some of the national EHR satisfaction survey data that's fairly recent, and we have a new vice president of EHR optimization and adoption. He's a physician, and he brought this to one of our recent meetings to say that 70% of job-seeking nurses say the reputation of a hospital EHR is a top 3 consideration. And many of you have seen that the California Nurses Association has been challenging whether or not EHRs are good for patient care. So we have a lot of controversy out there about the value of EHRs and how well they're working for the people who actually take care of patients. So these are all things that we've seen. I love the one at the bottom. 30% of nurses said their IT departments respond quickly. That means 70% of them don't. So they don't have a good view of us either in terms of how quickly we get out there, how well we help them in using the EHR to deliver care. So we were talking about the idea and the topic of my presentation today is kind of what got us here won't get us there. So the great implementation got us here. The selection of the systems, the quality of the work, the training that we did, the engagement of our staff, and having all of these groups. You saw John's governance groups. You've got all of these specialty groups. We have domain groups. We're engaged with those groups every month. We're looking at what they need. We're looking at what's coming in the next upgrade. We're looking at what we're going to deliver next. And we're in a much more rapid cycle of changing and fixing and improving the EHR. They're still not happy with it. So there's still more work that we can do. What we found out as Sutter Health when we looked at it was we focused on implementation. And we were really good at that. And I think there was a belief that all of us had that the system was so good and we were going to get all of these upgrades and we were going to have new things that were shared and that we were getting these from other health systems, that this would create that kind of care and feeding and a very viable and refreshing kind of environment for the EHR, and that would be sufficient. I think we all thought that. We're finding out it's not true. So what else do you do? We're doing all of that. It takes a lot of resources too, to take all of the upgrades, look at them, test them, train everybody on them, roll them out, help with the adoption to get new functionality out there all the time, and even that wasn't enough. So part of what we're looking at is what can we do? We also realize that there are lots of complexities in the technology, and this gets back to that old people, process, technology conversation. Because when you put something like this, even if we looked at the workflows, and even if we did the best we could to try to help people adopt the technology, it has unintended consequences, and it has a lot of variation in the way that people choose to use it. So even though they've got the same set of screens, you'll hear people like the way that they scan an index is different, and people aren't doing it in the same way, so people can't find documentation, and it starts to be more and more difficult to navigate through the chart because of the inconsistent way that users are working with it. So we had an initiative when we had over 1,000 backlogged requests. Now these come up through the regions and the domain groups. They come from the service desk. And here's this poor central team trying to gather them all together and prioritize them and try to deliver something back. So we had a big cleanup initiative, a tune-up for that. We delivered all kinds of improvements. That didn't fix it. We had a physician survey that said our physicians weren't happy, and our Physician Leadership Council was telling us that all the work they were doing in each of their own regions was also telling them that people weren't happy with it. So we said, okay, what do we need to do? Because what we're doing clearly was not enough. So our CMIO at the system level, and Sutter operates with a big central enterprise team, and then the regions help roll those things out and support our users in the regional areas. So our system CMIO went out and interviewed people in all of the regions. Now we started with ambulatory too, by the way. So when we talk about the journey, we've got all of our inpatient facilities up except for our last region. So our last 6 are due to go live in January. We're almost done. But these are all the people who are there, and it rolled out over a long period of time. So the earlier ones had more experience but were less happy because our implementation process wasn't quite as good on the earlier ones. So he went out and actually talked to each of the regions, and that's the first important thing. Stop sitting in conference rooms trying to figure out what to do. Go out there and start talking to people. Go back and interview your users again. Go back and observe on the units. Go out to the medical executive committees and start hearing from them what the issues really are and what matters to them. And we identified areas of focus for training and coaching and communication, because you put a lot of attention into rolling it out and the training in the beginning, and then nobody does any more. And if you're anything like me, if you're a Word or an Excel user, I use about this much a Word. I use as much as I need to, and when I get past that, I shove it at my assistant and go, here, do this. That it's past my competency point. It's got tons of functionality. It's got tons of capability. I could do all kinds of things with it if I had the time to learn it, but I'm busy working, and I don't have time to sit down and go take a class. And yet somehow I expect our physicians to do something other than that with the EHR. They're not going to. They don't want to sit in a chair. They aren't going to learn it on the job. They're going to get enough to get by. They're going to create a bunch of workarounds, and that's what's going to stick, and that's where they are. So we've got different workarounds. We've got different levels of expertise. You've got your physicians who are fabulous at this. They get it. They love it. They sit there. They figure it out. That's like, what, 5%? And you've got everybody else, and then you've got these at the end who hate it, and they're never going to like it, and you can ignore them. But this other big group has learned to cope with it. And one of the things that I found in talking with some of our physicians is we went live when I was at St. Luke's. We put in our EHR and ambulatory, and I had a physician who had finished all her charts by the end of the day because she would sit there and she'd just close them. One at a time, she'd finish her documentation as she went along, and she was really great. I had another physician who was there till 9 o'clock at night. Now this tells me that they're not using the same process. They've got the same EMR, but they haven't learned the same way to navigate through it, and we're not getting them all to the same place. I had one client that talked about this as well. They need remedial training, and actually, I hesitate to call it that. It's more they need intermediate training. So they learned the basics, and now they need to know the next level. So we need to kind of get them all to a level of proficiency and then move forward. And that was what we started to find out, was that a lot of what we were running into was just inconsistency, lack of training, and just enough training for people to make up a way to get work done, but it was very variable and not very standard, and we weren't teaching everybody the best practice or the easiest way to navigate through the system. And so we created ambulatory physician champions. Sutter started with ambulatory first, so we had a lot of users in the physician practices. And we started to request regional scope of work proposals. We said to the region, you figure out what you would like to do. Went to the CMIOs and the regional CIOs and said, put together a scope of work. Tell us what kind of a project you'd like to do and what you would accomplish with that. And we took it as a grassroots kind of bottom-up proposal. And we developed a system level, also scope of work. So the system was ready to support all this with trainers and with developers, because we obviously needed people to do the build work and the testing of the things that we were requesting from the regions. So we took that together and we introduced our continuous improvement program. And the way this worked was we agreed we'd use resources from our system and also from the regions. So we wanted to make sure that this was an integrated team. Because we have an enterprise team, they're very powerful, and they know a lot. And sometimes they think they know a little too much. And we had regional people who were using it to take care of patients, and we weren't getting the feedback that was coming up from the care delivery part of the organization, the people who really had the hands-on accountability to come back to the enterprise. So they said, we need to get together and talk to hear from our users what they really need. And then we would make sure everything operated in parallel, that we had the resources from the enterprise team that would be devoted to the work that we agreed to do through these various scopes of work documents. And we established our funding through meaningful use. So we took a big percentage of our meaningful use dollars and we set it aside as a set of funding. And the way we went to do that, we put a goal statement together. This is pretty much mom and apple pie. I don't think that this goal statement is anything that most of you don't have one way or another. And we put together some guiding principles. It was important in our decision-making that we not pave the cow paths. So there's a certain amount of requests that comes from people where they want to go back to something that feels comfortable to them. It was the way the system used to work, or it's something that goes with their current workflow, but it doesn't necessarily move them forward. And we wanted to make sure that we were thinking ahead, being strategic, and making sure that we were moving toward a future state, and that we all agreed that partnering together with both the regional and the system points of view, we'd really be able to make a difference. The thing that mattered the most was that the significant level of change that the whole EMR introduces into the environment, there's a whole lot of ripples through the whole organization. And the thing that we do when we train, when we talk about workflow, the workflow we train on is log on, log off. That's not the workflow for the caregiver. This is patient comes to the unit and I have this whole set of treatments. We found this in our cancer center. And we had a lot of problems because we had a various number of log on, log off things, and they were very disconnected. We had issues with scheduling where it didn't really translate to the exam room or to the patient flow. We had problems with wait times. We saw all kinds of things. And the enterprise team kept saying, it's training, it's operational, you guys can fix that, just let it settle down. And we're going, no, really, it's broken. It doesn't work, these pieces aren't fitting together. And so we redid our core processes from patient in the door and patient out. So we have a patient, a new patient, we have an exam room, we have various things that we do. So we have 6 core workflows. We redid them and then we redesigned pieces of the system in order to get that to work for the patient and for the caregivers. So in some cases, don't do it log on, log off, because that's just the workflow inside the EMR. Don't do the EMR workflow, do the actual patient care workflow, and you'll find where these gaps are. And we spent a lot of time with that. And we also wanted to make sure that we applied lessons learned from all over the health system. We've found when we get together that a lot of times when we talk, somebody in another region solved the problem that we had, but we weren't talking to each other, and we didn't realize that somebody else had figured it out. So we do a lot more sharing. We also created an oversight committee, which is an appropriate way to do this, and our CIO and our CMO identified leaders throughout the health system who would be on the oversight committee, so they would look at the scope of work proposals when they were brought in, and they would ask questions and they would send them back for more work so they could have measures for improvement, and then they'd approve them and they'd fund them. One of the things that was important that we were looking to make sure that whatever it was we did would be able to be adopted by other regions and also turned back over to our own staff. So we'd spend money bringing in consultants to help us design a new curriculum or do a good assessment of proficiency for our physician population. We did bring consultants in to pay for getting that done, but as soon as it was done, it became a program that we trained our own staff on and we took it over. So the idea was do something that had a perpetual and ongoing capability when we were done with it. And that was one of the things that the Oversight Committee made sure they weren't going to spend a lot of money and do something and then it would just end because the resources went away. This had to have some kind of self-perpetuating capability. So to the improvement focus, this isn't unfamiliar to everybody. The people part is important and the process part. One of the things we found when we went through that set of 1,000 requests was that 80% of them were for things the system already did. And you'll find when you go through a lot of the requests that come up, a lot of them are already there. You heard a theme today, I'm going to reiterate it a little bit more. We all have bought a lot of excess capacity that we're not using, and we've reached a point at Sutter where we say, you've got to prove to us we've got to buy something else before we're going to do it, because we're convinced that we already own whatever it is. We've got capability within all of this software we purchased. We have ways to work and get it back and use it more fully in the EMR or in all of our supporting capabilities, and we have to make that work. So part of our job is to get the full value of that investment out of there and to use that technology more fully, especially when we find out that most of the things they want to do are already there, which says we have a problem with the training or we have a problem with getting that communicated to our caregivers. The process, we talked about the workflow changes. We also had to put in really good change control because we needed to be able to allow the analysts in the regions to start making changes to the system. We've been holding on to that pretty tightly because it's a single instance. It made people nervous. So we put in good change control so more changes could be done locally and delivered faster. So our first example is from the West Bay region. They had the 6-year go live. They went live over a really long period of time. They were very early and they had lots, as you can see, a whole lot of different locations all up and down the coast, and they had to implement them a little at a time. So they'd had a lot of trouble with consistency, with adoption, with physician satisfaction, because it just took a long time. It had a lot of variation and a lot of people were unhappy with it. And it's a really big, complicated region. So what they came up with, and this is another one of the themes, is as we start to look at where we need to go, we're doing population health and all these important things. We started talking about personalizing care. We have to personalize the relationship we have with the caregivers. And what they actually did was develop a proficiency assessment, and they assessed every single physician on their proficiency, not by groups, but by actual physician. And this is what you can see up here. These were the various areas of proficiency, and of course, in EPIC, you're looking at how people use the problem list and the in-basket and various other capabilities. And so you can see at the top here, our top-level physician is not doing so well with 3 different things that are red and 2 that are yellow. We've got only one physician there who's all green, like right in the middle, where they're very proficient at everything. So what this allowed them to do was to say, okay, we now know where all of our physicians are and how good they are at using the EMR. And this was a piece of work that was done by consultants. So we built the proficiency exam with a lot of support so that we could take that tool and continue to reuse it. And so then they put together a curriculum for proficiency training. You don't have to see all the details here, but what they did was figure out for each thing they needed to train on, how much time they needed to train the physician in that capability. And then they developed individualized training plans for the physicians to be able to send trainers out to help them in each area that they needed to make sure that they could get through all the proficiencies. And a lot of them, as we round too, we see that people don't have preference lists, that they don't know how to use smart sets, that they're still really struggling, and there are a lot of things that could be added that physicians didn't get in the beginning, that if we go back and make sure they all have those, it's going to work a lot better for them. So you can see they achieved a really significant improvement in terms of proficiency, going from 64% to 97% by the end of the project. And those little gray bars are unassessed physicians, so clearly they kept doing the assessment and getting more of their physicians identified and trained. But the thing that was so important here was we actually trained our trainers in how to train a physician. That's the other thing. Don't send your analysts out there and have them all be variable in the way that they engage with physicians and they don't necessarily know how to train them. They all went through training programs so they knew how to deliver this and how to work with each physician to help them go through the proficiencies. And continuing to invest in your staff. We talked today about how do you keep people, how do you keep your staff? You train them so that they're competent, they're proficient. Don't bring in the consultants to do it. Take the time, train your staff. They become very good at it. They develop relationships with these folks, and they appreciate that. And they continue to go out and revisit them and help them, and you build a lot stronger infrastructure in terms of what your staff is able to deliver and also the relationship they have with the physicians and the nurses. And that's one of those benefits that we don't always think about when we're bringing consultants in all the time to do it. So use the consultants in the background to build everything, and then let your own staff be the people who get to go out and deliver it. So the follow-up was they have power users. So there are physician power users in each of the regions. And in the West Bay, they went out about a month after training, physician to physician, and checked to see whether or not they'd maintained that level of proficiency, and so they could see if there was any place else they needed help in order to get them all to that set of green capabilities. And they validated the retention of it, they reinforced the training, and they continued to build the relationship between these physician power users so that any physician out in practice, if they had a problem, they would call one of these physicians to come and help them. It's one of those things where we don't send the message that when training is over, you should know it. It's like if you get stuck or you're not doing it very often. Now, one of the things, too, that they did was we created the Sutter Wiki, and we've got a whole lot of stuff that we've videoed, because a lot of times you don't do things very often, and when you want to, you just need to go online, find the video, watch it, and it'll tell you how to do what it is you want to do. That's been very good, little consumable pieces of training. And then the Sutter Wiki now, of course, as soon as we finished that, was available to everybody throughout the whole system. And that was something that our West Bay region did. They did a fabulous job with it, and it's been very popular and adopted very quickly. So we got the benefit in the East Bay of the work they did by having all these training materials available, and we also can take that proficiency tool and apply it in our region because it's a set of capabilities now that's a repeatable program. In the Central Valley was the first one to go up on the EHR, and their physicians really hated it, and they didn't adopt it. They had a real adoption problem. They had a long-standing issue with the physicians feeling neglected and that people hadn't gotten back to them and that they had a lot of problems that weren't being addressed. And so Central Valley said, how do we get involved more directly with the physicians, and where are the problems? And what they found was for the family medicine and the internists, basically the primary care physicians, the system was fine. It was the specialists who were really unhappy with it because it's built on a kind of a generic workflow, and they found that the specialists were getting really annoyed because specialists don't look at everything. So cardiologists only need to see what they need to see, and pediatricians and the gastroenterologists. So they were finding that this great big set of stuff with a bunch of things they didn't need was annoying. So the Central Valley came up with a program to find ways to build new navigators for the specialists. They found the unmet expectations for ease of use were primarily with the specialists, and the cumbersome change process, the external pressures for them with meaningful use and adoption meant that they couldn't have bad adoption by the physicians, and they really had to get that up to a level that would comply with meaningful use. So they went ahead and took this on. They started regional pilots, and this was another thing. We've touched on this also this morning. You kind of have to go fast and fail fast in this environment. So you've got this big macro thing going on with population health and your infrastructure and all of your business intelligence. At the same time, you've got to get your caregivers up and going. You want to start really small pilots and see if they work, and do them very quickly and iterate them quickly and throw it away if it isn't good. And if it is good, then you can start sending it out to larger groups of people. So finding ways to do small things well and quickly at the time you're doing the larger things, we need to do both. And we need to find a way to use our resources to be able to meet both of those needs. And I thought that the way that Central Valley did this was great. So they were specialty focused, they did them one at a time. And they simplified everything, they built it quickly, they let them use it, made them use it for 4 weeks, and then they would clean it up. So there was this iterative process working very closely with this group of specialists to get them what they needed. The starting point, and you don't really have to be able to read this, the problem was it was, give you everything. It's like, here it all is. And for the specialists, it's just annoying because all that stuff is not necessary for them. And it didn't have good visual cues in it, so people were poring over it and looking at it and trying to figure it out, which wasn't working. So their iterative workflow, they did 12 weeks. This is a pretty fast cycle time. They deliberately made it fast. So they got together for 2 days with a specialist to design the new system and their navigators and to try to get exactly what they needed. Then they built it, and they would put it out, and in 4 weeks in production, and they'd come back and redesign it. And they achieved a lot in a very short time by focusing the attention on one specialty at a time and rolling them out. And the value of that is that we got them. So we took the hospitalist navigators and brought them in right away. So we didn't have to do all that development in our region because they'd done all that work in Central Valley. They actually invited some of our physicians over to their design sessions so that they could sit in and provide feedback. So they actually reached out to other regions to get other clinicians engaged in that process. So their objectives were to give some visual cues so people could drill down into things and to try to make it, to keep them from having to go back. Drives people nuts to have to go back to another screen. They want to keep going forward, and they wanted to work it so that it flowed. So they got some good design principles put together when they worked with the physicians, and they kept that up in the way that they structured each one of these. And they also used the sidebar and the header to reduce that reverse flow, so people didn't have to go back and find things. They could keep dropping down and come back to the screen and select things right from there and keep moving forward. So there was a lot of conscious thought in the flow of the design and the way that the screens worked, not just what was on them. And those are the kinds of things, too, that when we share those, it's just good design principles that we're learning, and they can underlie other kinds of work we do when we start doing this for nursing. It's like, this is what we learned, and there's a set of design principles, not just what the screen looks like or what's there. And that's saving us a lot of rework. Because a lot of times people, if you go and sit with a physician, they go, this just doesn't work for me. Look, this thing is a mess. I'm over here, I'm over there. That doesn't translate into how I fix that for you. It's really hard to try to distill it all down and understand exactly what's wrong with it so that you can fix the workflow issues and the clinical information issues at the same time. And this is something that as we share this, we become more knowledgeable about how we should do the analysis and how we should structure our work. And then they also moved more activities in, and they categorized the activities within the navigators. That made a huge difference. Now that's the way that the screen looks today. So you saw the first one, which had everything everywhere, and now it's all broken out. People know where to drill down. Things are in good logical order so that people can see what they need to do and when they need to do it. And that's made a huge difference for them. And the key to success in this is prioritize the optimization. So they decided to work on the specialists. They did them one at a time. Make sure that you're very clear when you're going through this work and that they engaged physicians in these design teams very specifically so that they knew when it was their turn. Started with the hospitalists. Starting with the hospitalists is usually a good idea because they tend to share what's going on and what they like, and they circulate a lot around the hospital. That was a major win. And a specialty focus was important. Having the local analysts doing the builds. And physician builders, those of you who have Epic, send some of your physicians to the physician builder training. They don't usually come back and want to build, but they come back with a real appreciation about what it takes to actually build screens. So I've found that when the physicians go and they learn this, they usually come back and go, well, now that I know it, I don't want to do it, but I want the analyst to do it, but I understand it better. And so particularly with the specialists is to get a few physician builders back to that training so they've got that deeper knowledge of how the system is put together and how it operates so that they can be the champions but also the reasonable representatives about how all this is supposed to work. And then lots of leadership support. And what they found was it re-engaged the disaffected users because they brought them back in. They said, you are important to us. We are going to focus on your specialty. We're here. We're going to work with you. And those design sessions were very lively and well attended, and they got a lot of value out of discussing what the clinical needs were, about how the EHR worked. And of course, these were people who'd been using it for a long time. And that's what's important, is that optimization can start any time, and some of it's better when the system is more mature and your users have kind of gotten used to it. They know exactly what they need. And it's important to be able to bring them all together so that they can share that, have somebody listen to them, and have somebody bring something back that actually addresses exactly what it is they were looking for. It was very matched to what kinds of issues they'd been having. Simplification was a relief. We've given them too much. In a lot of cases, we want to give them everything. We want to have them be able to pick everything, and they really wanted it to be stripped down. They knew what they needed. That was one of the things that I found with all of these physicians. When you get them together, they'll go, the biggest problem I have is I don't need all this. So if you just strip away what they don't need, you're kind of down to what they do need, and that was very helpful. Same holds true for nursing. We're starting to put together a scope of work for nursing because all the attention went to the physicians. And I don't know about your health systems, but we had a tendency to focus so much on physician adoption, because that's what Meaningful Use said, that we've been neglecting our nurses. And they are really, really irritated with the media tab, which they call the junk drawer. You know, go out and ask them what they call things too. You'll find out what they don't like and what they think of all of this. And the media tab, that just needs to be cleaned up, standardized. You need to get everybody using it the same way, because it's a mess in a lot of areas. The in-basket's a problem. Blood transfusions are a problem. Moving patients from levels of care are a problem. So there are pain points. And a lot of times, we did this with the Cancer Center when we did our improvement. We went out and interviewed them, and when we did these core process flows, we also started identifying pain points, and then we did walkthroughs in a conference room. We put all of these core flows up on the board, and people came in when they had time and took yellow stickies and stuck their pain points on the wall. We had 97 technical pain points and 86 operational pain points throughout 8 core processes in the Cancer Center. Well, that told us there were serious things that were wrong. A number of them were workflow or operational. Some of them were staffing. A number of them were system-related that we needed to fix. But it's really important to find ways to do that so that your caregivers know you're listening to them and that you're talking to them in their terms. You're hearing about what the issues are from the patient flow, from how they're caring for patients, what parts of it are causing them problems. And a lot of times what you can do to improve it is just taking away the things that are cluttering everything up and streamlining the handoffs. It's all falling apart between registration and the waiting room and getting the patient to the exam room. So a lot of times this is where the system falls apart, is between where one function logs off and another one picks up. And we found that when we go through that workflow, it makes a huge difference to our caregivers. And then it also, when you go through this kind of meeting, it re-engages everybody and it positions the whole community of users, whoever they are, to actually adopt the new changed system, because you have to get them back on your side. They've been alienated, they've been put off, they've felt that you didn't care, didn't understand, didn't get it. And so this is a chance to reclaim the relationship that you have with your caregivers and that your staff has. And we've really optimized that. I think optimizing not the system, but optimizing us and how we work and how we ask questions and how we engage and how we show what's important to us is part of the work. We've got lots of talented analysts, and we really needed to change what they were doing. We needed to train them so they could train better. We needed to teach them so they could ask better questions and they could design new workflows. So this is not optimizing just the EHR, but your team and your own approach to how do we keep getting this to go better and better. And Scott's slide with the 1962 comment, you had said that, I wrote this down, we're going to be at it for a while. We're going to be at it forever. So don't get tired, don't get worn out, and don't think you did anything wrong. You didn't. You're in really good company. This is something that as soon as you get something done, they want something else. They're never going to be satisfied with it. They're never going to sit there and go, this is wonderful. I love it. It's great. It's going to be more, and it's going to change, and things are going to be different. We're going to create different care teams. We're going to be taking care of our patients differently. All this population health, the sepsis management, that's all great. We can produce lots of great information. Try to operationalize that. You've got all these alerts. Now you've got to go intervene with all those patients. You've got to find these people who have these conditions. You've got to get them cared for. You've got to get them moved to a bed. You've got to track all that. A lot of times the operational side of this is really challenging for our care teams. We can put a lot of information in front of them, but they actually have to consume it, and they actually have to put it into practice when they're caring for patients. So the more we understand that and the more we get engaged with it, the better off we'll be. So we had some nice comments from our physicians, and I've got them here for you about how they felt. And the thing that's interesting is it wasn't just the outcome, it was the process. And they were very much more reassured that we cared, that we were paying attention, that we were working on it, that we were smart people, that we understood the system, that we added some value. So you can see, they said how efficiently real progress was made. And that was the other thing, keep it small so you can move it along and bring it back. People complain about us being a black hole. I don't know if that happens to you. I ask you and you go away and you never come back. I asked for that 3 months ago. We did a value stream, we're doing lean. We did a value stream on our EHR requests from the regions up to the enterprise, and when they came back, Our average cycle time is 192 days. And in our value stream, we thought we'd get that down to 73. That's going to be so exciting. So whatever you can do locally to do a little faster than that so people can see you working on something and get it back to them, that's very helpful. They appreciate it. And you'll see that they talked about good involvement from the community physicians and the MAs and the support staff. Make this kind of a larger enterprise. We have been working on the changes in the cancer center. We have the physicians saying you can't get the oncologists very often. You got to get them before clinic and after clinic, and they're really busy people. But we've engaged people from registration and scheduling, from the lab, from pharmacy. We have all of our key caregivers and the people who help to care for a cancer patient end to end when they come into the Comprehensive Cancer Center, working in that so that when we present it to the physicians, they can see that the entire workflow works for the patient. And that's important. So get everybody involved in the process. We have a few more little comments. I like pediatrics, clinically relevant, and a friendly environment to dissent and argue constructively. That's one of the things that we have to create, because this idea you're going to be doing it forever, if you can't create that friendly environment for them to discuss clinically and dissent and hash through it to come to agreement, we're never going to get anywhere. So that, to me, is more of the important outcome than the actual new navigators, which is great. But creating this kind of dialogue and having something that persists, so the next thing we take on, we've got that kind of working group, and we have a way of having those kinds of conversations, that's exactly where we have to go. Because where we're headed, I look out there and think, you know, patient accounting, whatever we call revenue cycle, is going to be dramatically changing as we go to paying for value and away from some kind of fee-for-service reimbursement structure, and who knows what that's going to look like. CMS is looking at compensating us for telehealth. We're doing virtual visits. Right now, we pay our doctors for the virtual visits, so they'll do them. But CMS is going to start looking at that. We're going to start seeing people paying us for new kinds of things. The whole world's going to change on us. And we need to be ready by having an approach with our EMRs or whatever else we're doing, but it's as good a place to start as any, for engaging with our clinical teams and for being the people who bring forward new capabilities and are constantly listening and improving and making that caregiving environment better. And that's the thing I think that's the best thing that we can do. So the summary, you can optimize the EHR. And when you finish this cycle, whatever it is, if you use these approaches or others, and if you go out and ask for proposals from your various caregiver teams or from your facilities or however you want to do that, you'll get some great ideas. Ask them to tell you what it is that they think would make the biggest difference for them. And go ahead and make it a program initiative. So we do put resources aside to optimize. It's not something we do on the margins. We have staff, we have time, we have a process, and optimization is a piece of the work. And that's important. Proficiency requires tailored training. You can't go in there and have a one-size-fits-all training. It's got to be very focused on what that clinician needs and where they are, and meet them right where they are, and you'll get a lot of value out of it. And make sure that you've got shared interest groups, and I like that success begets adoption, so when you have that new relationship, they're much more anxious to make it work because they were part of it. We didn't do it to them, we did it with them. We always think we're doing things for people, and they feel like we're doing things to them. We need to make sure that we're doing things with them, and that's the way that we work all the time, and we need to think about that. We at Sutter have to work on an us and them between the enterprise and the regions. You know, us and them is kind of easy to do, because we sort of see the enterprise as the grandparents who come in the morning and swoop up the kids and take them anywhere they want, buy them presents all day and feed them anything they want and bring them home. And then we've got to make them eat vegetables and go to bed on time, do their homework. So we've got an us and them that pervades, because there's a lot of money at the enterprise side and not so much out in the regions. We've got to kind of keep things tight. So we're trying to look at that from a Sutter perspective and say, how do we take advantage of everything we've got and bring it to serve our clinical teams, and how do we make sure that there isn't an us and them and we aren't underutilizing all the talent that we have in the system. So we do have time for a few questions.
How important is having a nursing informatics council, a CNIO, for your organization?
I think it's critically important. I think that our nursing counterparts have a lot of understanding of what's going on with our patients, and also they're the ones who have to manage a lot of things like our length of stay and the sepsis protocols and a number of things that we're starting to put out there that have to do with readmissions and various other things that happen with our patients, and we haven't been listening to them enough. And I think that our clinical workflows with our nursing executives, I really liked John's structure where he's got a CMIO and a CNO together as dyad partners. I think that's very, very important. We kind of lost track of that at Sutter, and one of the things in our new reorg is putting nursing right up there at the top again. So if they're not, they should be. I think they're critically important to that. They have a lot of knowledge the physicians don't have because they're there all the time, and so they see the patient from different points of view, and you need all of that. I think that's a great question.
We have another question back here in the corner.
Hi, Adrienne, Karen. Can you talk a little bit about how you have approached quality program in terms of reflecting that into the workflows and helping the end users understand the data capture and motivating and driving that?
Yeah, we've been spending a lot of time on quality, and we're starting to look at how we need to do that throughout the enterprise, because right now the quality measures kind of exist inside each region. So from the regional perspective, one of the things that we have is a quality council. So we have people coming together, and then we're using Lean. So we have a number of A3s that have been set up with targets for quality improvements, and they're very specific. So we set up measures for those. I love that idea this morning about how you have a financial close every month and you ought to have a quality close. I think that's a great idea, and I think there are closes. We're still very retrospective. Healthcare for so many years, all of our data was retrospective. They used to laugh at us looking in the rearview mirror. One of the places that I worked, we found out our revenue was up and our volumes were down. And everybody goes, that's perplexing. What's going on with that? Took 2 months to figure out that we had an increase in some profitable surgeries. So we were making more money because we had a particular increase in the profitable surgical services that we were doing. But we didn't know that for 2 months. Well, that's not acceptable. So part of this is to get the quality indicators to be things that you're looking at all the time, and that you have specific targets to get them done, and having a quality council, bringing together nursing. The problem with quality is sort of like medical records. They took a bunch of people and said, here, you're the quality people. That doesn't work, just like it wouldn't work here. It's all got to come back together, and there has to be a group of people. I also like the idea of setting time aside to say, you, and you are going to spend a half or a quarter of your time working on getting our quality measures from here to here, and these are the things we need you to do. It needs to be a real piece of work with time. It can't be something you sit in a committee and then everybody's supposed to go and do it somehow when they're already 100% committed. The mistake we make is just not making quality a piece of work. We make it kind of peripheral to a bunch of other people's jobs instead of central. And I think that as we do that, we're seeing a lot of improvement in the key areas that we're working on. Just as an aside, we saw a presentation recently from the advisory board. And one of the slides really struck me because what they said was, you used to be able to go out as a hospital or healthcare organization and directly set your rates and basically work with each of the health plans to put something in place for your system. And the health plans aren't operating like that anymore. They're basically going to create networks. They're going to bundle us all together. They're going to take that network and they're going to sell it and partition it out. And one of the things that they showed us was one of these payers was saying, if you don't have your quality metrics here, we don't want you in our network. And that really took me aback, because it used to be the quality was kind of ours, and if we weren't doing it, that was kind of too bad, and sooner or later Healthgrades was going to out us, but we could argue about that and say that doesn't really mean anything. That's not going to be true anymore. We're going to stand or fall based on whether or not these measures are good and they can be validated. And we're going to have to get there sooner rather than later. So I think the quality teams are critical. And this way of working together is critical. And having analysts that we can embed in there, because they each need their own. We're doing lean work now, and they're calling me up going, I need an analyst all week in the ED because we're doing a Kaizen. It's like, gee. My analysts are busy rounding and doing this other stuff. I've got to start inserting people to gather data to support this. But that's exactly where we're going, and that's the level of engagement and relationship and embeddedness we need to be successful.
Any additional questions? Please join me in thanking Adrienne for an awesome speech.